Well, while people are still joining, again, welcome to the SEMPQIC Coalition meeting. As you know, this is a special meeting that we added on this year. Normally, we don't meet in December, but there's just so much going on our end, and certainly with, COVID. As of yesterday, the vaccines are out. And we just felt the need to get back with our group to hear from you guys again as to what's happening out there on the ground, and to share with you some very current things that SEMPQIC is working on as we get ready for 2021. It's been a rough year, but as far as the work that we've done, I think it's been a successful year. And we want to continue that right up until the end. So again, welcome. We appreciate you coming out and taking this time so close to the holidays. I want to encourage you to really take advantage of the chat because we have so much to cover, not enough time for everybody to speak. And we do want to hear everybody's thoughts, questions, comments, input. So please take advantage of the chat while we're talking if things come to mind. So we want to be sure that we hear you. Why don't we start with Dawn Shanafelt from MDHHS with an update on COVID and the vaccines. And I will mention that as we speak, the governor is having a press conference right now. I just saw Dr. Khaldun talking to folks. So Dawn, we're glad you could join us.
Thank you so much and thank you everyone for giving me the opportunity to share these updates with you today. And if you could advance the slide, that would be great. Perfect, and you can advance to the next slide. On December 7th, the epidemic order issued by the Michigan Department of Health and Human Services was extended until December 20th. Based on data-driven decisions, the following situations to the right on the screen in the pink or reddish area were paused. This includes in-person learning for high school, college, and university students, indoor dining for restaurants, movie theaters, group fitness classes, and a variety of areas where multiple people would come together. Next slide, please. The Michigan Department of Health and Human Services Immunizations Division has released a newly developed website for provider support during the COVID-19 pandemic. And I encourage all of you to visit this website at michigan.gov/vaccines during COVID for resources for vaccinating in the midst of a pandemic. On the next few slides that I'll be sharing, you'll see the impact that the pandemic has had on our vaccination rates, in particular for children. Next slide, please. As published in the CDC Morbidity and Mortality Weekly Report, Michigan has seen a decline in childhood vaccination coverage during the pandemic. The gray dots on your right, on the this area to your right here, the slide, are the vaccination percentages for children from 1 month of age to 2 years for the time period of May 2016 through May 2019. So again, those are the gray dots. The yellow dots that you see here are the vaccination percentages for each individual age category for May of 2020. So you see that we've seen a decline in all areas with the exception of infants that are 1 month of age. Next slide, please. The above graph, also found in the same CDC MMWR article as was shared in the previous slide, shows the vaccination percentages by milestone ages for each individual year. So you can look at those individually, and you can see that for the most part, things are fairly stable, except when we get to May of 2020. And again, in all areas from 3 months, 5 months, up to 2 years of age, there's been a decline in vaccinations for children, which is very concerning. Michigan is part of the CDC COVID-19 Pregnancy and Neonate Surveillance Project. And our Michigan statistics as of yesterday, or December 14th, are detailed here on this slide. Since January of 2020, 1,111 women were confirmed COVID-19 positive during pregnancy. Of the women that were confirmed positive, 564 have delivered their babies, and thankfully all 564 of the babies were delivered as live-born infants. You'll also note the prematurity rate. So of the 564 babies born, 15.9% were born premature. And of those babies in total, 11.9% were admitted to a NICU. And 1% of the babies tested positive for COVID-19. I want to point out a clarifying comment here that all of the babies that were born premature may not have needed a NICU stay, which is part of the reason why the NICU percentage is lower. And then also some of the babies that were admitted to a NICU were admitted for reasons other than being born premature. So some other type of medical concern or concerns where they warranted more intensive care. Next
Question,
slide,
Dawn.
please.
Dawn,
Sure, Vern.
Yes. You move off of this slide. For example, the preterm birth, is that higher than preterm birth for women delivering during this time who did not have COVID?
It's higher. Well, so we don't have the data for 2019 or 2020 out yet for preterm birth, but when you look in comparison to 2019, yes, that percentage is higher. Absolutely.
Okay, thanks.
You're welcome. Next slide, please. I think it's critically important to share this information, and I'll go over it a bit. It was also highlighted in the press conference that Governor Whitmer and Dr. Khaldun held at 1:30 today. It's important to share that extensive steps have been taken to approve the vaccine, going through each of these 3 phases of clinical trials. So vaccines are tested on adults first in the 3 phases, beginning initially with 20 to 100 healthy volunteers, then moving to several hundred volunteers, then moving to hundreds of thousands of volunteers. So even though the vaccine for COVID-19 that's been approved thus far by Pfizer was expedited in the approval process, every single step still occurred. It was the urgency of this pandemic that we were able to move the virus into fruition much quicker. But I want to share that that quickness doesn't mean that any steps were skipped or that the virus is any less safe as a result of it being created quicker. It's also important to note that the FDA licenses a vaccine only if it's safe and effective and the benefits outweigh the risk. Vaccines are made in batches, and you'll see that on the bottom left of the screen, and those batches are called lots. Each individual lot is tested to assure that it's safe, pure, and potent. And then also the manufacturing facilities that manufacture the vaccines are also inspected frequently by the FDA for quality and safety. Next slide, please. And this is an amazing slide. It definitely brought tears to my eyes when the vaccine was, put into production and began being shipped. So Sunday morning marked a monumental event in the fight against the COVID-19 pandemic. At 5 a.m., the first FedEx truck picked up the COVID-19 vaccine at the Pfizer Global Supply Plant in Portage, Michigan. So yay, Michigan. The MDHHS COVID vaccine website at michigan.gov/COVID vaccine. So that's michigan.gov/COVID vaccine includes a dashboard of the number of enrolled provider sites in the COVID-19 vaccination program. This feature went live on Monday, and as of yesterday, there are currently 297 sites in Michigan enrolled to be vaccine provider sites. In Michigan, 3,900 vaccines have been shipped as of yesterday to Washtenaw and Kent counties. And many of you may have seen the press coverage as Dr. Khaldun was at the University of Michigan when their shipments arrived. Next slide, please. I also want to point out that the department is following the CDC recommendations for prioritization of distribution and administration of the COVID-19 vaccine. The recommendations are based on input from the Advisory Committee on Immunization Practice, or ACIP. And this is a federal advisory committee made up of medical and public health experts who develop recommendations on the use of vaccines in the United States. And so again, as I detail the Michigan vaccine plan, note that it's in line with the CDC vaccine plan as well. So you'll see here that we have multiple phases. So there's 2 phases. And then in phase 1, there's multiple A, B, and C individual subphases. Each phase may not be completed before the next phase starts. So for example, some workers in essential and critical services may begin to be vaccinated while we're still vaccinating personnel who work in healthcare settings. So I think that's critical to mention that. And if you want more information, I'm going to detail a bit more in the next several slides. But if you really want to dive in and learn more about the vaccine and the phases and Michigan specific information, go to michigan.gov/COVID vaccine. And when you go there, you'll be able to see the dashboard that I mentioned and a host of other things that I think that are really important to share. Next slide, please. So as I mentioned, I'm going to go through the various phases and give you a bit more information on those. So you can see priority area 1. That's the critical healthcare infrastructure. So essentially our emergency medical providers. So that includes our first responders that go out in ambulances to the Michigan residents' homes or other places to provide them critical medical response. The general medical floors of hospitals, emergency department, and intensive care units are all part of priority area 1. And again, if you visit our website, you'll be able to see more information about the specific hospitals that are beginning to vaccinate their staff. So the University of Michigan, and then Spectrum is another hospital that's beginning to initiate vaccination. Next, a critical priority area is residents of long-term care facilities. So again, this is an extremely vulnerable population. And when we mention long-term care, we're referring to not only nursing homes, but skilled nursing facilities and assisted living facilities.
Does that include mental health facilities? Not?
If they're inpatient mental health facilities, then that would be part of the congregate facility if they're inpatient. But again, the priority areas for the hospitals initially are general medical floors, emergency departments, and intensive care units. And then also a third priority area would not only be the residents of long-term care facilities and the medical staff that I referenced earlier, but then also healthcare infrastructure, critical infrastructure functioning. So that would be areas such as like your laboratories, x-rays, individuals that move in and out of patients' rooms as well.
Dawn?
Yes.
Someone asked a question about expected moms. Are pregnant women expected to get the vaccine? Could you comment on that?
Yes, I'll get to that in just a moment. But I can tell you right now that the vaccine, apologize for the breaking, the vaccine is not approved for pregnant women at this time.
Okay.
Next slide, please. Phase 1B are other essential workers to keep critical infrastructure open. And I apologize, FedEx, speaking of FedEx, pulled out of my yard at this time. But included in this are K through 12 school and child care staff who have direct contact with children. And then also 16 sectors of critical infrastructure. And you can see those detailed on the slide. So that includes communications, chemical areas, food and agriculture, energy, wastewater and treatment facilities. So again, infrastructure, and then importantly, healthcare and public health sectors as well. Also included are homeless shelters, correctional facilities that include jails, prisons, juvenile justice facilities, congregate child care institutions. So that would be, if you think about things such as foster homes that are large settings where kids are, transitional housing would be covered in that area, as well as adult and child protective service employees, because again, they're coming in contact with families. And then workers with unique sets of skills that I previously mentioned somewhat. So I mentioned laboratories and clinical services that are within an institution, but then also non-hospital laboratories. So your freestanding or outpatient laboratories that we all go to have lab work done, as well as mortuary services. Next slide, please. And then phase 1C includes covering or administering the vaccine to individuals that are high risk of illness from COVID-19. That includes our populations that are 65 years and older. That includes individuals between the ages of 18 and 64 with chronic health conditions that could put them potentially at higher risk. So for example, coronary or COPD, hypertension, chronic kidney disease, heart disease, diabetes, obesity, and other conditions that put them at high risk. And you can find the specific list of high-risk conditions on our website. And adhere to the question that was asked. At this point in time, pregnant women are currently not recommended to receive the COVID-19 vaccine. And to add a bit more information to that, you mentioned you recall when I showed the slide earlier about the testing phases for the FDA. The vaccine has been tested on adults. So it has not been tested on children, and it has not been tested on women who are pregnant. And so at this point in time, that's why it's currently not recommended. But if you visit the CDC website and delve into it a bit further regarding pregnant women, you will also see that if a woman is high risk, it's recommended that she talk with her provider. So again, for an example, if you had a pregnant woman who had chronic kidney disease, then potentially her and her provider could determine that it's best for her to become vaccinated. But right now in Michigan, we are not currently recommending the COVID-19 vaccine for pregnant women. And then as we move into the final phase, that's essentially where everyone who's 18 years and older, who didn't fall into any of the other categories that I noted, would be able to get the vaccine. And all of this is supply permitting. So I think that's really important to note. And you've all should have heard Dr. Khaldun mention that as well too. So again, this is a supply and demand issue. And that's part of the reason why there are the critical categories of rolling out the vaccine. Because at this point in time, there's not enough vaccine that's been made to vaccinate everyone in the United States. This is very similar to the situation that was experienced during the H1N1 situation several years ago, where again, that vaccine was phased in because at that time there wasn't enough vaccine to vaccinate everybody. I want to make a quick
question, Dawn?
Sure.
How will the vaccine be distributed across Michigan?
So across Michigan, there are those 297 approved vaccine providers that I mentioned earlier. And initially, we're starting with, there's 56 hospitals and a subset of local health departments that are receiving the vaccine first. And that's based on a social index scale as to where the vaccine should go to be equitably distributed.
Thank you.
I wanted to make a comment again on pregnant women. The slide that you showed, I think it was over 500 pregnant women have delivered in Michigan who had COVID.
Correct.
So those women were, when they contracted the disease, they were further along in their pregnancy, maybe third trimester, at least second trimester. So we really haven't had any women with COVID who delivered that contacted the disease, say during the first trimester. So there's a lot of information we don't have about the impact of COVID, as it relates to pregnant women.
Absolutely, and that's why Michigan is in partnership with the CDC for this registry to collect that information, because you're absolutely correct, Vern. Even though we began collecting the information in January of 2020, or the data, we know that our first case of COVID in Michigan was in March, mid-March. And given the 40 weeks of pregnancy, we're watching closely, our maternal child health epidemiologists and our team, to see what unfolds for the women who contracted the virus early in their pregnancy. And hopefully there aren't any serious health complications as a result for mom or baby. But again, that's being watched very, very closely. I also want to point out too that you'll note that the data that I did share from the database for Michigan for women who were determined to be COVID-19 positive while pregnant. Very soon we'll be able to share with you all that data broken down by a variety of demographics. Right now, you didn't see the age of the mother. You didn't see, as Vern mentioned, the time in the pregnancy, what trimester she was infected. You didn't see her race, ethnicity, where she resides in the state of Michigan, or what regions, counties. So again, we're hopefully going to be able to share additional information or more specific information. The CDC has just transferred to a new data system that will allow us to pull that specific information out. I also want to point out, though, that information is collected by the state of Michigan in our disease surveillance system, which is why we have access to it and the ability to report it to the CDC.
And Dawn, this is Gwen. The SMFM just came out this past weekend recommending that pregnant women have access to the vaccine. And I was looking at the CDC, which recommended that if a pregnant woman is part of a group that is considered high risk and pregnant, that she can choose to be vaccinated with a discussion with her healthcare provider to help her make that decision.
Right, that's absolutely, thank you for that, Gwen. So that's, there's variation, obviously, as this is unfolding quickly and has been throughout the entire course of the pandemic. Right now, the Michigan recommendation, as noted above, is that pregnant women are currently not recommended to receive the vaccine.
Right.
That doesn't mean that they could not get it if there are extenuating circumstances. But again, that's between the patient and the provider, as well as access to the vaccine too, particularly given that we're in these early stages of vaccination.
There's a question in the chat as well. Are they reserving the second doses in groups before giving to the next group?
Thank you for that. So yes, not yes to the question, but yes, the second dose, I'll cover that in a moment, is required for the Pfizer vaccine within 3 weeks of the first, or not within, after 3 weeks of the first dose. So after 21 days. And then the Moderna vaccine that's coming out also requires a second dose. As far as reserve for the second dose, I can't answer that question. I'll bring that back to our immunizations team, but I don't work closely enough to know their specific plan about how they're, rationing out doses for the second round of vaccine. My hunch would be that we're hoping that, not hoping, that there'll be enough produced for the second round, right? Knowing that we're gearing up production at this time. But specifically how that's being handled, I can't answer that.
We know we lost at least one mother, at least it was in the newspaper, that mother delivered at Henry Ford. And I guess she was full term, but she had COVID. Anyway, she passed away, but the baby was healthy.
Yeah, it was a very
sad.
Very sad situation. There's been several sad situations. Mom of twins who's doing okay now, or improving. And then there's been several other cases where I've seen just some, heart-wrenching pictures of moms meeting their babies for the first time while they're in an ICU. So it's definitely a very, very scary situation.
Right.
Another question in the chat, how are vaccines being distributed to tribes, and are they part of the 295 sites?
I will go back to the immunization team and find out the answer to that question, because I do not know the answer. I know right now, as I said, that the vaccine's being distributed to the hospitals that I mentioned in the state of Michigan, as well as local health departments. How they're being distributed to the tribes with Indian Health Services and others, I do not know. So I will thank you for that question, and I will find out the answer.
Before we run out of time on this topic, as you know, many African Americans are not inclined to get the vaccine. One of the earlier surveys said that only about 40% say they're going to get it or are inclined to get it. So that's 60% that don't, compared to other populations. And we know that the African American community suffered more in terms of both the rate of COVID disease as well as the death. And also we are at very high risk when it comes to the chronic conditions that that often lead to death and very serious COVID. Many of us know personally people that have died, especially here in Detroit, when you look at the number of people that died from COVID. So the question that I want to ask is, can I hear from some of you what you think we need to do to ensure that African Americans also benefit from the COVID vaccine? Incentives, you know, I would like to hear just a few of you comment on that. And if you're not, if you don't want to comment right now, I would appreciate it if you would comment in the chat. I'm a member of the Governor's Economic Recovery Committee. And I kind of made a commitment to share with them some of the strategies that need to be in place in order to assure that African Americans also benefit. You know, access means acceptability also. So I would just like to hear a few thoughts on that before we run out of time on this topic.
Absolutely. I think that can the team members, the members of SEMPQIC, are you able to unmute yourselves if you'd like to share, or type in the chat box and someone from the SEMPQIC team can read the comments. I see a few popping up here. The suggestions are critically important.
Yeah. Go ahead.
Who was commenting?
Well, Dr. Holtrop typed, we need to involve trusted community leaders in getting the word out about the importance of getting COVID vaccine, including the faith-based community. And then Jay noted, I think the incentives make people more skeptical when it comes to vaccines.
Yes.
And there was
I've heard
support
that
for
idea
that.
tossed around about incentives, and as soon as it came up, the people in my circle are like, why would they pay us? Because they're trying to set us up. So that's definitely not as enticing. With the notion of involving the trusted community leaders, I think it's important that we don't skip the step of gaining the trust of community leaders, because also a lot of African American pastors and others, you know, activists and civic leaders also do not trust this vaccine. So we can't just go to the people that we know the community trusts and ask them to share that trust with this vaccine. So those groups need more education. They need to understand how the vaccine was developed, that it was built off of science. And though it seems fast, it's because there was already a body of research to build off of. Like that level of education with our community leadership core can be glossed over, so to speak.
Correct. I think that the information, what you just said about more information on the science, we shouldn't assume that people can't understand that. They want to know what's in the vaccine, you know, so we need to be willing to break down the science in a way that that people know what they're getting. That seems to be a big issue. I think we kind of dumb down maybe too much and when it comes to giving people information.
Kajada had a message. It popped up and then went away, but I think it's an important message. I don't know if someone could read it, or Kajada, if you want to unmute yourself and share.
Yes, Kadada, would you explain that, please?
Hi, I actually have another meeting right now, so I'll just say this. I've been on Twitter regularly, and there's a lot of social media backslash for Black people who are being seen as pawns to promote the vaccine. So I just want to share that. I see it throughout Twitter like all day. The videos, there's videos of Black nurses giving it to other Black nurses. There's commentary around Black people who are saying this is why I got the virus and so forth, and they're really being dragged on social media. So I just wanted to say that if we're talking about using Black leaders to promote the vaccine, then we also have to be considerate of what that might mean for their reputation and so forth. And I wish I could stay, but I'm going to come back at 2 o'clock after I get off of my 1:30 call. Thank you.
Okay.
Thank you, Kadada.
Yeah, I think that the community, quote unquote, community leaders and people from the community really need to be people that the community knows. You know, so Barack Obama is going to get a shot on television. You know, like they're not going to give me what they gave him. You know, how do I know that's what I'll be getting? And my thought is it doesn't have to be celebrities always. Someone else suggested that it could be bus drivers, cab drivers. One of my suggestions is that for people that work in hospitals, you know, it doesn't have to be a nurse. It could be somebody that works in the kitchen, as an example. People that have lost a loved one due to COVID in our community. So I think we need to think more ground level when we're talking about community trust. I heard a quote that someone said, it's not a matter of fact, it's a matter of belief. And the only way to change belief is through trust. So,
And Dr. Cheryl Gibson Fountain sent a video called Love Letter to Black America. I don't know who has seen that, but that's really good. And it kind of deals with that issue of trust and why we need to do this. And it's from healthcare professionals.
Yeah, I was just
Love Letter to Black America.
On what Vern was saying too about, you know, using leaders like Obama. I mean, there has already in the last, you know, week been conversation about the treatment of, you know, the administration, current administration, Congress and others, the different treatment and medical care that they get. So oftentimes people will not really relate to somebody at that level, you know, because they know they're not going to get the same privileges and or medical treatments as those who are in those higher positions or higher positions in government.
That's a very important point. And something else that I think that I think that trust is built when there's greater numbers of community members that have been vaccinated, so you can see for your own eyes. Do you know what I mean? So if someone in my family's got vaccinated and or received the vaccine and they're safe and protected, and I think that helps decrease fear because you personally know someone who got the vaccine and everything was okay, versus, as Vern said, a celebrity or someone that you weren't there to physically, you know what I mean, witness what they got. And so I think that trusted community partners or leaders are important, as well as members of your family and friend circle that you trust, that if they tell you they got it and they were okay, you believe what they say. But yeah, I absolutely thank you for all the comments, and please continue to put your thoughts, your important expert opinions in the chat, because they're very important to all of us, and as Vern said.
Thank you, Don. Before we sign off, I see that Dr. Jones mentioned the 800-pound gorilla, and that the vaccines have been politicized so much by the Trump administration.
Mm-hmm.
Definitely is not considered a friend of African Americans. And I've heard people talk about that. And I mean college educated professionals, not just people
Right.
tend to think you're talking about low income African Americans, but we're not. We're talking about very sophisticated African American professionals who are also very leery. So thank you for that. We don't want any invisible gorillas in the room that we don't face up to. And also, in closing, I think we need to face up to the fact that the paranoia and concern and resistance on the part of African Americans is actually legitimate and very rational, you know, based on the history, but not just on the history, also based on the bias that we know currently exists in healthcare, which is why, you know, we work so much on, you know, equity and systemic racism. That still exists very much so. So you should not try to disagree or argue or put down the legitimate and rational concern about, I don't trust this. That needs to be recognized and actually embraced, you know, in a way that accepts that, and then you have to go from that point of view. So again, thank you for those comments, and I'll be looking for more comments on your thoughts on what we can do better to assure that African Americans benefit from the vaccine. So with that, we're going to move on.
Okay, do you want me to wrap up the last few slides, Vern, or should we
Oh,
just?
yes, I'm sorry. I thought that was your last one. Sorry,
No,
Dawn.
it's okay. I'll just move through really quickly. I want to share that Michigan has an application or app called Michigan COVID Alert. You can download it on your iPhone, whether it's Apple or Android. Make sure you have your Bluetooth on, and it will alert you if you have potentially been exposed to COVID-19. And also the state does not save any of this information. It's mere the cell phones being within distance. Next slide, please. The SEMPQIC leadership has shared this with all of you, and I just want to implore you to read the Michigan Coronavirus Racial Disparities Task Force Interim Report, share it, and hopefully it gives you the same feeling of hope that it gave me when I've read it multiple times. Actionable steps were taken very quickly, and disparities gaps were closed as a result of those actions. So it's proof that we can make a change and we can do it quickly when we need to, which we need to. Next, just a few maternal infant health updates. Again, I've encouraged you before to go visit our website, and I'm encouraging you again. Thank you to the March of Dimes. We've just posted Toxic, a Black Woman's Story on our website, so it's able to be viewed by anyone who wants to view it. And again, I'd encourage you to share it in large groups on social media. It's an important short film that everyone should see. And then next slide, please. The dates for our 2021 Mother Infant Health and Equity Collaborative meetings have been posted on our website. If you click on the specific dates, you can register to attend those meetings. They will all be held virtual in 2020 with a focus not only on maternal health and mortality, but on raising the voices of families as well and addressing systemic racism. Next slide, please. We've released the Michigan Breastfeeding Plan for public comment. This is the first time the plan's been released for public comment. And I encourage you, again, go to our website and review the plan, print it off, review it, share your candid, honest feedback. And then the comments are to be routed to Shatoria Townsend, our Michigan State Breastfeeding consultant, and Shatoria's email is found on the webpage too. Next slide. We've added a variety of small videos and information regarding bias at the request of medical care providers and those that serve families that were interested on where do I start? Where do I begin to learn? Here's a great way to learn. Go to the website and start listening to the stories of families and learning about the true history of racial injustice in this country. Next slide.
I really like that. That's really great, Dawn.
Thank you very much, Vern. And here's my contact information. And as always, if you have any questions, want to reach out to me, I answer my phone, I answer my email. Please feel free to contact me. Thank you.
Yeah, someone asked for the link to the toxic video. How do they access?
So you go
How
right
do they
to
access it through your site, Dawn?
Okay, you go right to michigan.gov/MIHEP, and it's right on our homepage. As soon as you go right there, you can see the link and or see the video pop up and you can watch it.
Okay.
Thanks, everyone.
Thank you. Thank you. Well, we have some really very exciting news to share. You know, we've been working on equity throughout the existence of SEMPQIC, and it's our top priority. And I got a cough, a frog in my throat. So I am going to introduce Alethia Carr. As you know, Alethia has been our champion on, sound like President-elect last night. But at any rate, we got a grant from the Kellogg Foundation, which we're really excited about. It is $450,000 over a 3-year period, $150,000 a year to create a Detroit Health Equity Network. We haven't made a public announcement yet. We will soon before the holidays, but we wanted to share it with you first because we know that we would not have gotten this grant were it not for your work and the interest of our entire network in the issues of equity. So we thank the Kellogg Foundation, and Alethia will be our lead person on this project. So with that, Alethia.
Thanks, Vern. Next slide, Devin. In addition to talking about the exciting grant from Kellogg Foundation, I also want to share an initiative we're offering to the membership this year called our Health Equity Reading Circle. So you're going to hear about both of these things. Next slide, please. As Vern mentioned, with the Kellogg Foundation grant, we've proposed to establish a Detroit Health Equity Network that'll serve as a platform for health equity information, resources, and best practice exchange that will help organizations to better serve those at high risk for experiencing maternal and infant mortality. And just like we just heard about the information that the state has on their website with those resources, we're not proposing to create new resources, but make it easy for anyone that's interested in looking at that information to have a link to it. So we'll capture that link and be connected to it. The network will also create community connections that foster capacity growth for agencies to implement equitable policies, practices, and programs that help create system change to improve birth outcomes. We will plan to expand the platform in years 2 and 3 to enable dissemination of our lessons learned on a statewide basis, and the website will be developed to enable network scale. Finally, the network will coordinate efforts with the state health department, MDHHS, relative to achieving priorities in the maternal infant health and equity improvement plan for efficiency and effectiveness. And as we've said, this aligns with our mission of SEMPQIC to reduce infant mortality and maternal mortality disparities with a priority of achieving health equity for African Americans. Next slide, please. The goals of the Detroit Health Equity Network is to increase knowledge of health equity and the impact on access and quality of care, as well as health outcomes, to increase access to the tools on health equity that exist and resources, because there are quite a few out there now, but they're all at different sites. And so we really want to foster behaviors, use that information to help to foster behaviors that reduce bias in healthcare. We want to use a collective impact approach to assist organizations to build resource capacity and achieve health equity by allowing agencies to connect together to talk about and exchange their lessons learned and ideas for use of the resources that they've accessed, and create an infrastructure for health equity expansion, as I said, regionally and statewide, as well as evaluate the results and build sustainability. This is a 3-year grant, and we're not looking for it for the resources to go away after the end of the grant, but we want to make sure they are maintained and sustained. Next slide, please. The activities include, in order to increase the knowledge of health equity and the impact on access and quality of care and health outcomes, we'll identify learning modules that'll be shared online, provide opportunities for continuing education for SEMPQIC members, host webinars and workshops on various health equity topics, including implicit bias training, and develop online health equity dashboards that track the progress of outcomes and agency efforts. Our team will conduct an environmental scan to determine evidence-based health equity resources currently used. So expect to hear from us asking you these kinds of questions, just so we can have a baseline of what's currently being used in the community, with a priority given to agencies in the Detroit area that are serving Detroit families at high risk of experiencing maternal or infant mortality, and complete a community assessment and share the determined objectives and strategies as prioritized in the MIHEIP, the state's Maternal and Infant Health Equity Improvement Plan. We'll create a website that'll become the go-to place for information and resources regarding perinatal equity, including a resource library and other health equity tools and resources that'll serve to reduce bias in healthcare. We plan to have not only articles, but online curriculum, webinars that have been posted and that have useful information, really the whole gamut. As I said, we are building on the impact of collective impact to make sure that we use the results of the environmental scan and the community assessment to be incorporated into the work. So we'll use that information to help guide us. And we plan to provide a foundational training for organizations that serve Detroit on health equity and opportunities for individuals and agencies to share best practices, information and resources, and assist SEMPQIC organizations with implementing plan objectives through various opportunities, and will offer technical assistance. We will also identify key community partners, including local community representation, to serve on a collective impact advisory committee that will help to provide insight on what resources should be part of the network, as well as how they're used, and to share the lessons learned. So expect to hear from us as we invite you to participate in the advisory. An infrastructure will be created for expansion of the work, as I said, across the state. And once key partners for the committee and their roles are identified, the work for the committee will be scaled to reach other prosperity regions in Michigan. As Kellogg provided the funding, they were interested in us certainly targeting the Detroit area, but wanted to be sure that we were able to share our lessons learned across the state so that all of Michigan could benefit. And as I said, lastly, the work will be evaluated. The team will determine data and measurements to evaluate and measure progress, create a marketing and outreach program, and develop return on investment data for current and future funders. Next slide, please. Our expected project outcomes include that organizations will be armed with more knowledge of health equity and motivated to implement reasonable strategies to create healthcare system change that help to improve birth outcomes and reduce disparities. It's also expected that the information will be accessible through the network, will include data on evidence-based strategies, and up-to-date data on maternal and infant mortality that will assist organizations in selecting appropriate healthcare strategies as recommended by the Maternal Infant Health Inequity Improvement Plan. Organizations will be equipped with needed tools and resources that will assist with policy and program change implemented related to health equity. And the website will be available to include a comprehensive list of health equity tools and resources. The main outcome we expect to see from this is, of course, improved maternal and infant health in the Detroit Region 10 area. And that is the goal behind all of this. Next slide. Our structure, as you've heard, will be the web-based resource with various types and forms of health equity information. We'll have a collective impact advisory committee to help steer the effort. We'll have a health equity dashboard with key maternal and infant equity data. And I guess I can't emphasize enough that we are looking to use existing resources that will be available as part of the Detroit Health Equity Network and readily link to those resources. And then we'll have data collection as an integral part of the network for evaluation and use. Next slide, please. Our invitations are being developed now to go out to many of your agencies to invite you to be a part of the Collective Impact Advisory Committee. We expect the group to meet 4 to 6 times over the next coming year. And though the initial number of participants may be fairly large, we expect to work in subgroups, and you see them listed here. One may work on resource identification, another user reviews, and then identify ways for user connections, as well as provide input into our data dashboard. Obviously, the meetings will be virtual, and will probably be virtual even after we're able to, again, reconvene. You'll hear more about the Detroit Health Equity Network, but I'd like to move into, yeah, you can go to the next.
Can we have, Alethia, can we have
Sure.
comments on this
Sure.
first before we move to the curriculum we're talking about?
Certainly. Are there questions or comments? I haven't been looking at the chat, but I'll take a quick look.
Yeah, I've been looking at them.
Okay.
And I wanted to comment. I see a couple messages from Lakeisha Grant and Ernestine Mitchell from Focus Hope. So I wanted to comment that one of the unique things about this network is that we are very serious about having not just community input, but some community leadership. We know we need to contact or make contacts with the end users, i.e. the clients, not just organizations. So we will be depending on the community-based organizations to help us with that. Another advantage of having a local health equity network is that we will easily be able to build upon the skills of people right here in the Detroit area. There are many good things going on that can be shared. Usually if you get online, you see a lot of national models and all that's good, but we really want to take advantage of the expertise here in Southeast Michigan. We're very serious about being able to use, I'll just say trainers for now, but expertise from folks from our own community. So that's something that is unique about the Detroit Health Equity Network, is the relationship that we expect and hope that we build into the whole network. through the collective sharing.
Right, and that's really the emphasis behind the collective impact advisory.
Right.
We'll be using information from people here in the community that are using the resources to build and strengthen the resources that are available, and to instruct on, you know, the value, the lessons learned that they have experienced. A couple of questions that are in the chat in terms of coordination with Detroit Future City. We really look to coordinate with all of the various activities and resources that exist in this area, in this region. And there are a lot of them, we recognize that, but they're separate. You know, you have to know where to look to find them. And we're really looking to collect them all and capture them in a way that anyone that access the online feature can access it, can have connection to it. And then I noticed that a couple of people have already indicated they're interested in participating. That's just what we want to see. You will hear from us in terms with an invitation to participate. We're expecting to actually start the work of the advisory come January. So look for the invitation information in the next few days, because we'd like to, you know, make the plans over the Christmas holiday. And continue to comment in your chat, in the chat. I'm going to move on to the next item. Just real quick, because again, this is an invitation to the membership at large. This past year, we, our internal SEMPQIC team convened a reading circle, and we started with discussing the New York Times Magazine publication of the 1619 Project, and really had rich discussion and learning from that experience. And so we agreed that we would continue it this coming year. And this year we're going to be using Roots of Health Inequity, which is an online curriculum that was developed by the National Association of City and County Health Organizations. And we're opening it up to the membership at large if anyone is interested in participating. This curriculum has 6 units. We're proposing to review 4 of the units as a group. And then we're going to start mid-January and have a discussion once a month on the 3rd Tuesday to go over the information that's in the units. I'll facilitate the discussion. And as I said, anyone that wants to participate, let Devin know. Next slide, please. I just have a listing of the subjects that are part of the curriculum, so you have a sense of what's in them. And the curriculum is set up in a way that it really allows deep thought about it and insight into the subject matter, and then discussion about application, you know, in practice as well as within our community. We do plan to have an evaluation that'll be used to determine the impact and satisfaction of the experience. And the curriculum offers continuing education for anyone that's interested. As I said, if you know, if you think you want to participate, you can chat it in, or you can for sure contact Devin by January 6th. Because it is online, there is no limit to who can participate. So, you know, if there are others within your organization that you might want to be a part of this, certainly let us know. So with that, I'll stop. I think I went a little bit over, but
yeah, that's good. Thank you, Alethia.
Sure.
We do feel very strongly that for those of us that are in the community, in the positions that you all are in, as well as us, that we really ought to be grounded. We really ought to be grounded in anti-racism. We ought to be grounded in the history if we expect to influence others and make a difference. So basically, as Alethia said, we took it upon ourselves as a team to do this, and made a decision to open it up to any members, because as Alethia said, it's we aren't developing the curriculum, it's from NACHO. And it's a good way, if you haven't taken the time to work yourself through the steps of really understanding the roots of inequity and how we got to where we are, you're in a much, much better position to talk about change with this information. And guess what? It's free. So again, you can answer right here on the chat, and I see some of you have already, as well as get in contact with Devin. And I want to really give a shout out to Alethia for taking the lead in this work. She really is quite the expert and has done a lot of work, not just here in the state, but also nationally on equity with a focus on maternal child health. So we're really blessed to have Alethia on our team and taking the lead in this effort.
Vern, before we move to the next subject, I just want to highlight that Dr. Holtrop mentioned a webinar that is being sponsored tomorrow by the CDC that people may want to take a look at. She's included the link. Just didn't want folks to miss that. And again, we're really looking to make this kind of information even more readily available across our region. Thanks.
Okay, thank you. Iris, are you here?
Yes, I am.
Thank you. Well, we're going to move on to the roundtable discussion. Some of you may recall that last May, we got a lot of input from a session like this that we shared with the equity and other folks in Lansing that was working on issues around maternal child health and COVID. And Dawn, of course, our fearless leader, really does help us a lot in being sure that our voice is heard in Lansing. So we've arranged for this discussion, which is really the primary reason we created a special meeting right now, because time is of the essence. So with that, I'm just going to pass it to Iris, Dr. Taylor, to introduce the roundtable and talk about what we want to get accomplished.
All right, for the next hour or so, we're going to discuss the opportunity to have our members to have a discussion around the impact of this latest surge of COVID-19 on the maternal infant care. And joining us today, we're excited to have Jay Clemens from Community Health Programs, Strategies, Community Health Equity, and Wellness from Henry Ford Hospital. We have with us Kate Robertson Kane, who is a director of the DMC Hutzel Women's Hospital. We have Renee Gaillard, Dr. Gaillard, who is the director of Women and Child Service Line, Medical Surgical Nursing, Nursing Education and Research Development, Pain and Palliative Care Services, and Advanced Practice Professionals at St. Joseph Mercy Oakland. We have with us Dr. Theodore Jones, who is the director of Maternal Fetal Medicine, Beaumont Hospital, Dearborn, and Vanessa Hall, coordinator of All My Children, a MIHP organization. Each of the individuals from Ascension were invited but unable to attend. And so at the end of the roundtable discussion, I know we have other members from Ascension that may be on the call, and feel free at that time to be able to share any information or experiences that you might have within your organization. Each of the participants were given 4 questions to be considered in their discussion today. Question 1, how are prenatal OB appointments being impacted by this current surge? What are COVID-19 protocols for OB patients, including delivery, visiting restrictions? Are there any new issues, concerns that have arisen during this current surge? I'm sorry, the phone would ring when I start talking. Are there any issues, concerns related to equity or access that you would like to share? Are there any new policies within your organization? So we're going to start the discussion by beginning with Jay.
So good afternoon, everybody, and thank you so much for having me. I'm actually filling in for Dr. Monica Lee Griffith and have data that she shared with me that I can share with you all in response to these questions. Our COVID policies in terms of visitors is available on Henry Ford's website, but basically we allow one support person of the birthing person's choosing, and they can have, if they want to, a doula can be with them. And that has been our policy since the beginning of the COVID pandemic, that at most they can have two if one of them is a doula. But they can only have one support person with them, and it has to be the same person throughout their stay. But all of the details of that are online. When it comes to our prenatal visits and the delivery volumes, we do see that there's a dip where we are not seeing as many patients this year at the same time as we had last year. So the numbers she shared are for Henry Ford Medical Group at Henry Ford Hospital in Detroit and at Henry Ford West Bloomfield Hospital. So last year, between March and September, we had just under 3,100 OB intake visits. And this year, during the same time frame, we had just over 2,700 OB intake visits. So we're down by 11% in our intake appointments. And it's a very similar story across the board when we look at patients who are initiating their care with just having fewer pregnancies showing up, and the deliveries are also a little bit lower this year compared to last year. I can only speculate on why that is, with people delaying care or taking a pass on care due to fear of coming into the system. And I don't have the month-to-month variation in front of me to say if we did better in the summer months than we're doing right now, or vice versa. But that's just kind of a snapshot that Dr. Lee was able to share.
Okay, thank you. We will go on now to Kate. You're going to have to unmute yourself.
Okay. Hi, Dr. Taylor. I'm sorry we were on mute.
That's okay.
I also brought Lisa Katzman with me today. So thank you for inviting us. She's our manager of our labor and delivery antepartum unit and our OBED over at Hutzel. So I'm going to let her go ahead and answer some of the questions. I can tell you the first question that we were asked is, how are the prenatal OB appointments being impacted by the current surge? I can't answer that question for you. I didn't get with David Gonawicked, who runs our OB clinic, so I can't answer that question today. But I'll let Lisa take the next question.
Sorry, my chair's kind of low. Hi, everyone. I see a few familiar faces. So basically, the protocol for our OB patients are very similar to Henry Ford. We are allowing one significant other at the bedside, and there are exceptions, something like a loss or a unique situation that we will consider having two visitors there. Doulas are allowed at the hospital as well. I would say, other than that, we're really asking our visitors to kind of stay in the room, and they're not, coming and going all day. We're asking them to kind of commit to staying here with the patient. If they have to leave for an extenuating circumstance or go to work or something of that nature, they can leave and come back, but we're really just trying to minimize the in and out. As far as our volume, I would say I've only been here since September. Our deliveries are pretty much on equal with last year. Hopefully we're going to meet our target for this year. We're just slightly down a little bit. We've had some extremely busy days, and then we've had other days where there's hardly any patients here, and it's really kind of a unique, sorry, just gotta move for a second. It's kind of a unique situation when you go from being extremely busy, and those of you that have worked here, how busy it can get, to having one patient in the high-risk unit and one patient in labor and delivery. The staff are telling me like they have never seen anything like it, the swings. So it's pretty volatile, I would say, as far as the ups and downs. But overall, our numbers are pretty well averaging out. I would say is how is it the issues? It's really just having everyone be ready just to kind of go on the fly. You know, one day we have a supply chain shortage of one thing, the next day it's something else. You know, we had a shortage of all things of fetal scalp leads, you know, and that was like a crisis. It's like, how can we work without a scalp lead? So we're borrowing from our sister hospitals, and then the next day or 3 days later, you know, there's hundreds of them. So, I mean, it's just, it goes from one item to another. And we're having to, you know, kind of keep it at the desk and almost like, you know, sign out a scalp lead. I mean, it was just crazy. I would say with PPE overall, we're fairly good on that. We go through a tremendous amount, and we're asking the staff to really conserve things such as face shields and so forth. And as far as the staff, you know, I would say in general, I don't know all of the staff here. You know, I've only been here for 2 months, but it's hard. I'm sure everyone feels the same way. They're working short. You know, when it's super busy, you just can never have enough staff here. And, you know, it takes so much time to don and doff. And when you're in the rooms, you're in the rooms for, it just seems like hours for a delivery. And we've had a number of staff out with either symptoms, and they're either positive or negative. It just depends. But it's been pretty impactful in our staffing. And we're working with the staff to have them cross-train a little bit more. I came from a hospital where we were pretty much all cross-trained. Here they are not, and that's what we're working on so that we can better flow the staff to the different areas. And I would say that's it, unless you have any other questions for me.
Are there any equity related procedures or incidents or concerns or discussions that are occurring?
I would say that there's really no inequity issues that we're noticing. Everyone that comes in, we are COVID testing. If we do have someone that refuses, then they're being treated as a PUI. And we haven't, to be honest, had that many people refuse. Our C-sections or patients coming in for elective procedures, we're trying to get them all scheduled so they have their COVID results prior to coming in. And we've been fairly successful with that. Just kind of as a side note, not really knowing the system here, the person that does all of the scheduling and the COVID scheduling testing and everything for us went out is out right now for a few weeks. So, you know, we're trying to pick up the pieces and figure out how you schedule all these patients and everything. But we're, you know, we haven't missed a beat, and they're all coming in and getting pre-tested before, which is a huge, huge help to the staff. And we are getting our COVID test results fairly rapidly. We've worked on a nice system with the lab, and we're usually getting them back within a 3-hour window. So that's helpful.
All right, our next participant, Renee.
Hey everyone, hi to all my friends too. It's good to hear and see you. I would start by letting you know that our OB appointments, I think probably like most of the clinics, there are virtual appointments and there are in-person appointments. MFM is doing all of their work in person, generally speaking, and they have initially limited the number of people that can come to an ultrasound, you know, because usually the whole family would show up to an ultrasound, but the patient is allowed to bring one person with them right now to that. So they also are following all the same COVID PPE platforms that we are. Our visiting policies for labor and delivery are just as Henry Ford and the DMC described. We allow one support person with mom and a doula if there is a doula. Trinity, generally speaking, is following the same CDC guidelines across all of our hospitals for the same rationale. And we do the same thing, one visitor 24/7 around the clock for antenatal, labor and delivery, and mother baby. If the baby does go to the NICU, we allow the parents because, you know, we figure mom isn't really supposed to be driving herself around, so she needs to get here, so she needs a support person or the whoever her choice is to be with her. And that goes for our pediatric population as well. So minors under 18 are allowed 2, and laboring patients 1. So there, we have had a few issues, I'm gonna guess somebody has, where families are informed. Oh, I see Kidada, I am at St. Joe's, Oakland. So families are informed prenatally of all this, but you know, sometimes they don't hear it till they arrive. And we've had a few grandparents who have been majorly disappointed that they can't be in the room with the family during the birth.
Oh, I would be so disappointed.
Yeah, I know, but it's just very hard.
I know.
Yeah, so we've had to let down a few grandparents. We try to let them down easy, but they're very disappointed. We did get in our NICU a camera that's called a NICVIEW camera. We had a donor give us 15 NICVIEW cameras, and what that has allowed us to do is for the families in the NICU, let their families outside of here see the babies. You know, we figured if you can visit with your family on Zoom or whatever in a traditional manner, much like we're doing today, you should be able to see your baby because the whole family wants to see that baby. It does not record, it does not have audio, but it does give families access to view their new little one in the NICU so they can at least see what's going on. Initially, the staff were like, oh my gosh, we're gonna get phone calls coming out of our ears from stressed out parents or grandparents if the baby's crying or, you know, we have to do something, but that hasn't happened. Everybody's been pleasantly surprised, and it does have the option if you are going to do some kind of procedure with the baby that you are trying to not have everybody see that, it'll let you slide the camera shut, and but it's got a little thing that says, we're taking care of your baby right now, we'll be right back, you know, that kind of a thing. So that's new. It's not because of COVID. We had that donor, but it showed up at the right time. So that's been a nice add to our service. The thing we miss the most, honestly, in the NICU, I know this isn't all about NICU, but it's all related, is our cuddler service. Because our cuddlers were in with us, helping us cuddle the babies, the NAS babies, or those that were in need of that. And the staff missed them terribly because they were a great add, because we can't have volunteers in the hospital right now. So that would go under my new issue or concern from COVID. Equity related, you know, we were fortunate enough to have a surge in volume of about 13% until last month, where we have dropped, as Henry Ford has said, a little bit. But what we were able to do is take our data that we've gotten from our collaboratives, the Blue Cross Blue Shield OBI collaborative, as well as some of our other collaboratives, and we were concerned that we wanted to make sure that we were giving as equitable care as possible in our center, and we had a statistician run them for as many variables related to demographics, ethnic origin, all those kind of things that we've been talking about all day. And our data came back that honestly, there's not any inequity in our care practices to various populations that we serve. So that was a nice launch into knowing that we're giving equitable care in our community. So we were very proud of that. So
excellent.
I probably talked way too long, sorry.
No,
What else can I help answer?
I'm sorry, Renee, what did you use to measure, what was used to measure the equity in practice?
Alethia, we looked at all of the variables that you described earlier. We looked at age, ethnicity, origin, zip code, all all those type of things, insurance, uninsured, all those kind of things. You know, I can talk to you more offline and we can go through that, but that it was a nice step into knowing that for our community. Obviously, we have much more work to do, but it was a good start.
Thank you.
Thank you. Dr. Jones, you have to unmute yourself.
That always helps.
Yes.
So good afternoon. So just a few thoughts. The prenatal visits, we too had been trying to use a telehealth model and try to space out our visits more than we had before. I used that same strategy for my imaging center. And so we didn't do as many ultrasounds, follow-up ultrasounds. We also were doing, interestingly enough, less antenatal testing. And so the usual twice a week testing became once a week testing. And as best as we're able to see, we have not had any obvious effect on perinatal morbidity or mortality related to that. So that's an interesting observation that we'll have to flesh out more to see whether it is absolutely necessary to do twice weekly non-stress tests on all these patients. I'll come back to the telehealth when we talk about equity and access. We did, in terms of our protocols for OB patients, we were using similar standards that everyone else was. At the initial peak, of course, no visitors. Then we started doing the universal testing on patients. So probably about the third week in March, we went to that. We had then started to, after the peak went down, started to allow the visitor back in with the patient. We delayed on allowing visitors in for the ultrasound for a couple of weeks, a couple of months beyond that, because we weren't testing those patients as they came in for their imaging. And so more recently, we have started to allow patients to have a visitor for that visit, as well as for their doctor consults and their genetic consults. It seems as if there's, in that sense, there's actually an incentive to do it by telehealth, because you can have another person there with you when we're doing it by telehealth that you can't have when they come in. We also decreased our access to elective induction of labor. So we sort of put the kibosh on inductions, except for where you had a medical indication that put you in our level 1 for inductions. We have since, after that first peak, sort of allowed that to loosen again, but we're starting to reevaluate that as we're getting into this peak, and about whether we may need to deal with that. One of the things I think that we don't always realize is that, it's one thing to have, let's say, a COVID-19 patient, positive patient on labor and delivery, and how that affects your nursing care and your nursing availability, because that person, you really don't want that person dealing with any other patients, obviously, and there's sort of one-on-one with that person. But once you start having more than one COVID-19 patient actively laboring, it really affects your ability to move and flow between rooms, because you really don't want to be going in and out of rooms dealing with COVID-19 patients and then dealing with COVID negative patients. When you look at what our ICU colleagues do, they're very good about sort of isolating and being very intentional about the flow of health personnel and who's going to be seeing who, and avoiding that a possibility that they're moving back and forth between. So it has put some stress from time to time on our nursing staff and on the physicians and how they think about who they're going to evaluate and when, and try to create as least amount of cross contamination as possible. New issues, I would say, or concerns. For us, it was primarily related to something that we hadn't anticipated. So we've had a couple of critically ill patients who were in the ICU, and we made a determination that that person needed to be delivered and delivered before we airlifted them to another hospital because they had become so critically ill that they really needed to go on ECMO. And so we found out the hard way that that there were choke points in terms of just moving to another part of the hospital for the delivery. And they literally had to disconnect this patient from her ventilator in order to get her in the elevator that we needed to use because it all couldn't fit. So they had to bag her while she was disconnected from the respirator. It had to be taken down by another elevator. These were things that we learned, valuable lessons, and it is creating, after the fact, of course, a sort of a logistics flow in terms of what we need to do and how we avoid that problem happening in the future. I would say that the equity access issue for us has been this whole sense of uncertainty about COVID-19 and the fact that people associate hospital with the presence of COVID-19 has indeed caused people to sometimes delay coming for care. And so as I listen and talk to my maternal fetal medicine colleagues around the country, there's a concern that that we need to look and see what sort of morbidity is associated with the unintended morbidity. In other words, other individuals who they don't have a COVID-19 issue, but they're not coming in as quickly to be checked on because they have a headache and they have some blurred vision and some other things going on. And so we have to reassure our patients, I think, better that we still need to see them in spite of the fact that we don't really want to see them unless we absolutely have to, but it's important for them to get care. So that's one equity issue. The other one, and that disproportionately impacts Black and Brown individuals. The other one for us is there's a lot of difficulty for telehealth in Black communities in terms of having access to internet that really works and is compatible with the needs for having a virtual visit. And so we frequently will have to, we have good intentions about being able to do that, but the reality is the equipment doesn't work. They don't have great internet. There are other issues that might be going on with their actual hardware. And so we've had to do a lot of work and work around that. There's not enough capacity or willingness to have individuals who can help troubleshoot for patients their needs in order to be able to interact with your health system and make sure that they're connected. And a more thoughtful health system would start seeing this as something that is a really important thing to do to make sure that their patients are able to get care. So I'll stop with that.
Very good. Thank you very much.
Iris, just one question for Dr. Jones before we move on. Just looking at the data, I see that Oakwood is delivering a lot more babies than in prior years. I just noticed that as we've been looking at deliveries. So I'm just saying from the point of view of SEMPQIC, that we're really pleased that you're participating, and we need to figure out ways so that, you know, Oakwood Dearborn is one of our major partners, because in fact, Oakwood delivers more babies now than Hutzel. And I was really surprised when I saw that you are carrying a major load, I'm sure, for Detroit, as well as Wayne County.
Well, thank you for noticing.
Very good. Thank you very much. We look forward to your partnership. Joining us today, we also have Nafisha Maron from Ascension. So we're going to ask that she give comments representing the Ascension environment. And then in place of Vanessa Hall, we have with us Deshauna Johnson, who is the president and CEO of Mother's Friend, or MIHP, who will then follow Ms. Maron. Nafisa?
Good afternoon, everyone. So I'm going to give you updates based on our maternal infant health program and conversations that I've had with our nursing staff and with our social worker as it relates to how moms are being affected by the pandemic. I kind of feel like in the beginning, we weren't really getting a lot of return visits from moms. However, as time has gone on and people feel a little bit more comfortable, it's kind of 50-50 where we get the appointments and we're able to still see them via telehealth. Right now, we're offering all telehealth services unless there is a need for baby items and or safe sleep. So if they have that need, then the staff will go out to do that with the proper PPE equipment. We've also heard from several patients that they have a hard time getting into the OB because of their restrictions. Some moms have told us that they've had to go every other month instead of every month. So they don't necessarily feel comfortable doing that. But again, this was all kind of when everything first started. We're starting to see more moms now get into those physician offices and making sure that the staff encourage them to go and seek those services as well. I can say that our referrals have increased, which is surprising, but necessary. We've seen a spike in domestic and sexual violence. The unfortunate piece of that is because we're not going into the homes, we can't really decipher what the needs are over the phone with moms. So it makes it really difficult to determine if there is any neglect and or abuse as it relates to the child and or kind of determine what's going on with the mom. So we've also had some issues with scheduling where we've noticed that sometimes we'll go check our OB schedules and there won't be any new patients. As you guys have already said, there's a lot of patients who are in fear of going to any hospital settings or any clinic setting. So we try to do the best that we can and walking them through labor and delivery, signs and symptoms. If they have any concerns, the nurses are, available via text message, sometimes after hours to provide them with support, and the social workers as well. So it's kind of like a roller coaster. It's been up, it's been down, but I think we're kind of steadying out. But there are still multiple barriers that these moms are facing as it relates to the pandemic. Another one is moms are having difficulty taking their children into their well baby visits. Many moms are not working right now and don't have babysitters for their other children. And due to the clinic restrictions, they're not able to bring anyone in with them. So that ultimately results in them canceling their prenatal appointments and or their well baby visits for their infants and or their other children.
Yeah, I can see how that would be an issue.
There are a couple of other associates of Ascension on the call today from Ascension St. John. I don't know if they have anything else that they might want to add as it relates to the questions that you all have.
This is David Zelensky. Can you hear me?
Yes, can.
Okay. Thanks for allowing the participation. From the OB appointment standpoint, I think Dr. Jones covered that pretty well as far as what we're seeing as well. The providers have kind of bumped out a little bit some of the visits that were more routine. So there is some spacing there. I would agree with what was said earlier, probably one of the biggest barriers for patients coming is this lack of someone else able to take care of their children, and they feeling that they can't come to their appointments because of that aspect. So that's really something that needs to be worked on to be able to facilitate moms being able to make their appointments. As far as our antenatal testing in that right now, with the second surge, we've gone back to no one coming in for antenatal testing other than the patient. Obviously, that's a dissatisfier for the significant others to not be present for ultrasounds. But we do make as available as we can, either through phone or through telehealth, the ability for them to be able to participate, but just not on site. As far as in OB, in labor and delivery itself, visiting restrictions like everyone else, one partner and one doula. Any new issues with this? No, I think we're actually a little bit more calm this time around compared to what we were with the first surge. A lot of lessons learned, so nothing really new during the current surge. Overall, Ascension from a mortality standpoint with the first surge was looking at around 23%. I'm not talking just obstetrical. But overall 23%, and that's down at 8%. I think a lot of that is lessons learned over time. Plus there's been a shift to a younger population than what we initially saw with the first surge. And then with regards to equity, Ascension right now has a major undertaking where we're looking at the SMM, trying to decrease that rate overall, and also improving our prenatal postpartum care component. And both of those issues with a fine-tooth comb looking at the equity component of it. The SMM, actually, as we have started with this, has gone up, and our suspicion is that COVID may be playing a role with that.
What is a SMN for? Everybody's not
Severe
clinical.
maternal morbidity.
Severe maternal morbidity. Okay, thanks.
Yeah. So we don't know. We're going to be breaking it down further. We're going to have patients separated by whether they were COVID positive or negative to look at that issue. But that's what's going on the equity front with Ascension right now with regards to the obstetrics.
Okay, thank you very much. Deshana, need you to unmute yourself.
Hello, Dr. Taylor.
Hi, how are you?
I'm fine.
Thank you for fitting in.
No problem.
So would you like to share a little bit about this second surge, what that impact has been on home visiting? Any challenges, any new challenges, any equity issues?
Yeah, the new challenges are the kids are back to school. So mom's trying to juggle the kids being in school, and some of the younger kids need mom sitting right there with her for them to stay focused. Therefore, mom doesn't have a lot of time to make her appointments and to probably take care of herself. So we're seeing some more stress there. They're not able to get to the resources that they need. So we're doing a lot of drop-offs for people. And basically, we're doing a lot of telehealth because like Dr. Jones said, they don't always have the technology for you to do the video visits. So you have to accommodate them and meet them where they are. And I'm still in the clinic. I've still been going. And I do see the no-show rates are going up because people still have the fear of they're going to get, exposed in the hospital. So there's a lot of stigmatism out there that we have to dispel in order for them to feel really comfortable, and especially around that vaccine, because they're listening to people on those social media platforms, and whatever they say, that's what they're believing.
Okay, all right. So Vern, having had an opportunity to hear what's going on within each of the hospitals, we'll open it up now for questions of any of our panelists or any comments from anyone from the audience, and you can facilitate that. I turn it back over to you.
You're turning it back over to me? Did you say Vern?
Yes, I did say Vern.
Okay, for some reason, I cannot see my attendee list right now, and I don't know why.
Go to participants.
Can't see.
Hit participants. The names will come up.
Well, I wish I could.
In the meantime, while you're looking for that, Vern, I'll mention that in the chat, there is a note that parents, the comment about parents not being able to bring their children into the doctor's office when one child is due for M and they have other children. This information shares where one clinic was able to schedule the family at the end of the day and allowed all the children to come in and then disinfected the visit afterwards. I don't know if you want to say more about that, Dr. Holtrop.
Only that this was quite time consuming and required us to go through the back doors in order to get clinic staff to agree to do this. It's not an easy thing to arrange. Several of the clinics have some protocols in place in terms of protecting families against COVID. And if they have a clinic specific website, some of them have posted it on their clinic specific websites, but some of our academic centers don't have that. And so one of them, it was Ascension St. John's, the resident clinic, we actually created a YouTube video that we posted on a website for them that allows, that basically describes what they're doing to keep patients safe from COVID. And it's very helpful when you're talking to families to be able to show them that. But we haven't quite figured out how to make this available on a routine basis. And that also that video does not really address what do I do if I've got multiple kids. So I don't have good solutions here. But by doing it at the end of the day, if there's any way to get through to someone within the clinic to negotiate that, that does seem to be something that some of the clinics are willing to do because they are concerned about kids not coming in for wellness. So they're willing to make some adjustments, but you have to get a hold of somebody in person, and that's not always easy.
Well, I have a question for any one of you or anybody else on the phone. I can't see my chat box, but my question is, several of you mentioned the issues with technology. I mean, I have my virtual visits and I have to often depend on the technology. Call the guy, the number that they said if you have problems to get help. Things quite often don't go smoothly. Does anybody have any systems in place to actually help the folks that are calling in for those video visits, especially lower income? They may be using a cell phone as opposed to an iPad or a computer. Does anybody actually give out working technical equipment so that they will have it? Is there any systematic way within any of your systems or home visiting that this problem is dealt with? It seems to be pretty pervasive.
We actually have been giving at Henry Ford we have a small library of tablets that we purchased in response to the pandemic and hotspots to go with it. All of the patients that have access to that also have a direct relationship with the CHW, which helps enable us to get them back when the time frame is up. And we did also, I put this in the chat, we bought I think 600 blood pressure cuffs and a smaller amount of Dopplers to loan out without expecting that we're going to get all of those back. So, and are, you know, doing a lot of patient education so that people know how to use those tools and how to communicate back what they need to if there's a problem.
Is anybody else doing anything in particular with that issue?
Vern, this is Teresa Holtrup from Kids Health Connection. We do asthma home education visits and virtually using doxy.me, and that sometimes works and sometimes doesn't work. And so we actually have a whole protocol worked out as to how to make sure that we have contact information for families on an emergency basis. And I'm happy to share that protocol. And most of the time, basically, they revert to phone calls.
Okay.
Hi, this is Lakeisha at Focus Hope. Focus Hope, we supply our families who needed tablets with tablets, so they asked for it. We supplied them with tablets. We also made sure that we gave them a flyer that Comcast was doing low income internet type things that they can call and reach out to them. So I know several of our parents was able to get on that program. And then when all else fails, if we can't do our virtual home visit, we can go into a phone call and just speak to them over the phone, whatever is easier on the parent, because ultimately we don't want them to become overwhelmed and don't want to participate anymore.
Yeah. This digital divide, I know, is also impacting education. You know, they don't have it for the kids either. When so many of the kids have to have the virtual classes, it has been a real problem. It might be one of those things as we look back on this COVID experience, that as a community, as a policy, being able to be connected electronically, it's just about as important as having food, because without it, you do not have access to healthcare. You do not have access to education. So I think we really need to give that a lot of thought going forward as one of the lessons learned from COVID. So, this is interesting. I can't see the chat box, so I don't know if anybody else has other questions or not. Yes, Renee?
No, actually, no, this is Sue Goff from United.
Oh, Sue, okay.
Yeah. What we've been doing is we've been supporting University of Michigan's virtual prenatal care program, and we've been providing blood pressure cuffs and Doptones and things like that. So I think in the future, being able to do some of this virtual prenatal care will be helpful to folks, even once we get through this pandemic.
Right. And that blood pressure cuff is essential. That is absolutely essential to be able to have and you all know that you're the OB experts, being able to know what the blood pressure is and providing those or being sure that they have those, that is absolutely essential. Is there anything else in the chat?
Horace from Centering Healthcare Institute mentioned that they found Wi-Fi access a major problem.
Okay. Well, we know we have to address that. At one point, we actually applied for a grant to provide smartphones to everybody. We didn't get that grant. But that was one of the things that we had hoped we'd be able to get funding for, but that did not work. So we have a few more minutes. If there are any other questions or comments, I think this has really been very, very helpful. And like before, we will be summarizing what we've learned and sharing that with other policymakers, particularly for sure in Lansing. And I think the other thing I would comment is the increase in domestic violence and child abuse. And I've heard that before, that as a result of people being at home, stuck at home for months, with kids who are not behaving, and one person may have.
Dr. Jones has raised his hand. Dr. Jones has raised his hand. I think he wants to make a comment.
Dr.
Yeah,
Jones?
and this is probably just to be provocative, but a colleague of mine sent me a piece, and some of you may have seen it as well, from the Brookings Institute. An economist wrote a piece about the fact that while we have this sort of narrative that people have that when we have these unusual events in our lives, natural disasters or whatever, it leads to this bump in births because people are together, and so propinquity leads to new births. But they're saying that when you really look closely at this data, it doesn't really translate that well, and that the nature of the event really dictates what will happen, because financial insecurity or financial security is really the driving force, and oftentimes for people to have more kids. And so they're actually postulating that there may be a 300 to 500,000 birth dip over the next year related to that. And so we may all have to deal with some change in volume related to the fact that people just don't feel comfortable thinking about having another kid right now.
Yeah, that is true. And that's interesting. If you could share that article, I'm sure we'd be interested in it.
Yeah, I can forward it to you.
Yeah, at least forward the link. Some of the other things that, yes.
Hi, it's Lisa from Hutzel. I would like to say something extremely positive. This has been on the news, so it's public information. We had a huge clap out last night. We had a major positive success. Our patient that many of you probably have heard about, that was featured on the news, that had a twin delivery. She was here on ECMO for 31 days and she went home last night. And it was so amazing. And it was beautiful. And it was a huge, obviously a huge success. And it was so weird because the nurse discharging her, pushing her wheelchair through the whole lobby of staff. And it just naturally happened. But one person on the other end, right by the door, was the person that was in triage when she came in. Now, what are all that coming together, on a random day at a random time? And the nurse in triage has spearheaded, and they've adopted her for the holiday. And I guess this weekend they're going to drop everything off and kind of do like a caravan in front of her home and just drop everything off. And if you have followed the story, she's got one child and now 2 sets of twins under the age of, I think, 2.
Wow.
2 sets. So,
wow.
and going home from a catastrophic illness. So it was beautiful. And just to see her, she was just so overwhelmed by the spirit of it all. And it was just so beautiful to see.
How long was she on ECMO, Lisa?
Approximately 31 days.
Wow.
So
on that good news note.
Yeah, there you go.
Thank you. And I do think that COVID is bringing out some good news stories. So just to wrap it up, I'm not going to summarize everything we've uncovered here, but this has been an excellent meeting, and I assure you that we'll be transferring this data, this information to many of the folks that are involved in making decisions as we go forward about COVID, as well as other health policy. Again, many of you will be receiving a letter from us asking you to participate in the collective advisory committee for the Health Equity Project. If you're especially interested, you don't hear from us, you can always contact us and be proactive about that. We're really excited about being able to do that. Also, if you're interested in joining us in the NACHO, Understanding the Roots of Inequity, you still have, of course, you have time to do that because we'll be starting in January. So I really want to thank everybody for participating. As we move towards the holidays, please remember the people that have lost loved ones this year. It's been a very, very difficult year. And there is a lot of people that are in pain or that will be grieving or that will have to be alone because of the policies that are in place. So please think about those people, and I know that you will take an extra effort to reach out to those that you know might actually need somebody to reach out for them. And I want to wish you all a happy and safe holiday, and just kind of open it up to Iris and Alethia or Lisa, if you guys have any quick comments you want to make. This is our last meeting this year. It's been a fantastic year.
I think you've said it all, Vern. I wish everyone a happy and safe holiday, and we definitely look forward to seeing you virtually or not next year and continuing this work.
Iris? Done. So
I was trying to get off of mute. Likewise, I would like to extend my holiday greetings to all of you, and my prayer that you all stay healthy and be safe as we move forward into whatever the challenges might be in 2021.
Okay, well, thank you all. Please enjoy the rest of the day and the holiday. Thank you so much.
You too. Take care.
Thank you.
Bye-bye, everyone.
Bye.
Right on time.